And we're back with Marc Surdyka. How you doing, Marc?
I'm doing well, Chris. It's going to be an exciting week. You and Tony Camella are coming out to Phoenix to film some content. Chris helped me with a pretty comprehensive ACL series that I think people will enjoy. So he's going to come out and help with some of that filming.
Yeah, it should be exciting. The goal for today is to dive into all things patellofemoral pain. This is going to be another episode of these practical guide series. For people that haven't listened to the previous ones, that first one we had was episode 210, low back pain, a practical guide. 5 episodes later, plantar heel pain and plantar fasciitis was 215. Again, what we're doing with these is making them practical, and they're also paralleling these resource guides that are PDFs that we're putting for free in the monthly newsletter. So individuals that are subscribed to the E3 newsletter will get the patellofemoral pain in likely a few days after this podcast comes out, the 1st of October. So anyone who isn't subscribed to the newsletter, check them out. And then I think eventually, once there's enough resource guides compiled, we're going to put these on the website as well. So for people that haven't received the plantar heel pain or plantar fasciitis, the low back pain, these will eventually be available for anyone, but would recommend subscribing to the newsletter as well. But this episode is going to be all things patellofemoral pain. Marc, can we just start with what actually is patellofemoral pain?
Yeah, I'll give my typical description and I'll do it, kind of in layman's terms, but patella refers to your patella or your kneecap, while femoral refers to your femur or thigh bone. So the patellofemoral joint is just where these two bones meet. And therefore, patellofemoral pain is just a fancy way of saying that your knee hurts. It's usually non-traumatic in nature with diffuse pain gradually presenting behind or around the patella with activities that load the quads or, more generally the knee extensor mechanism. So things like squatting, jumping, running, going up and down stairs. And then symptoms may also present with kneeling or prolonged periods of sitting. And sometimes that's referred as the movie theater sign. And now there's other names for patellofemoral pain as well. So it used to be called patellofemoral pain syndrome. I don't hear that as often anymore. And I don't think the word syndrome is very beneficial for what we're describing. For runners who experience patellofemoral pain, it might be called runner's knee. Sometimes it's just anterior knee pain, but that's the general gist of patellofemoral pain.
And then even previous to patellofemoral pain syndrome, a lot of individuals heard chondromalacia patella. Was that kind of the same thing, but just a more specific visual or description of which quote unquote specific tissue is involved? Can you touch on that a little bit?
Yeah, so there was actually a 2016 consensus statement by Crossley et al. And as you can imagine, because this was like an international consensus statement, there were a lot of the top researchers and clinicians on the field. And part of what they did was trying to determine what's the best terminology to use for patellofemoral pain. And they recommended not to use chondromalacia patellae. And there's several reasons for that. One, as we'll get into, imaging is not required for the diagnosis of patellofemoral pain. Patellofemoral pain is not usually managed surgically. And then this idea, this chondromalacia patellae, which chondro refers to cartilage, malacia means softening. So chondromalacia patellae just refers to a softening or breakdown of the cartilage on the backside of the patella. But this doesn't necessarily influence the prognosis of patellofemoral pain necessarily. Like, it doesn't change the management. So there's also a paper by Vanderheiden et al. In 2016 that found no difference in the composition of the patellofemoral cartilage between patients with patellofemoral pain and healthy control subjects. So yeah, oftentimes that kind of diagnosis or terminology just creates more worry, than being actually helpful. So it's recommended not to use chondromalacia patellae to refer to patellofemoral pain.
And you earlier on discussed some of the things that people can experience or that are ways to help rule in patellofemoral pain, these anterior knee or knee extensor loaded activities or prolonged sitting, different things that help clinicians or patients clue in on I may be experiencing patellofemoral pain. But what are things that as a clinician or as a patient we would want to rule out or consider as differentials for patellofemoral pain?
Yeah, like other things that we've discussed, patellofemoral pain is typically described as a diagnosis of exclusion. There's not a special test that you would use to pinpoint something as patellofemoral pain. And perhaps for the physical therapist or physical therapy students listening, they might be familiar with like the Clark's test or like this patellofemoral compression test that you can do when you compress the patella and contract the quads. And if you are a physical therapist or you are a student who's done those tests, you know how painful they are, whether or not you have patellofemoral pain, and you would never do that on somebody who is experiencing patellofemoral pain. So for it being a diagnosis of exclusion, we would go through all of our normal checklists, right? Is it coming from the low back? Generally unlikely if you have this diffuse anterior knee pain. Is it coming from the hip? Maybe, but also less likely, but, going through that checklist. And then, as I alluded to, in general, we're thinking about it being anterior knee pain. So we're thinking about the structures on the front of the knee or structures that can contribute to symptoms on the front of the knee. And then we're also thinking about age ranges, right? So patellofemoral pain does happen in adolescents and adults in the general population. So that is a consideration. So in, let's say, kids and adolescents, one, is it traumatic? Because normally it's non-traumatic. If it's traumatic and they're having this anterior knee pain, we might be thinking, did they have a patellofemoral, a patellar dislocation or subluxation, right? You might be thinking about Osgood-Schlatters based on the location of the pain. Or someone who's older, not that there's a specific cutoff, maybe there's osteoarthritis. So I would say like the big things for anterior knee pain, general population, is it not osteoarthritis? So maybe age range, stiffness, is it, patellar tendinopathy, this pinpoint pain at the patellar tendon? There's discussions about, is it the infrapatellar fat pad, this Hoffa syndrome, which might be more irritable with extension, although the fat pad might still be irritable with just patellofemoral pain. But yeah, you're thinking about those structures on, once again, anterior knee or structures that contribute to pain on the anterior knee and trying to rule that out. And generally non-traumatic in nature.
For people that want more details in this, I would highly recommend watching or reading the blog or the YouTube video from E3, Why Your Knee Hurts. This came out, I don't know, 6+ months ago, but Marc, I think you did a phenomenal job differentiating and outlining those things you just mentioned within this video of visually looking at the different areas, the different signs and symptoms. And ultimately, I think the management can be very similar for a lot of these different diagnoses, but sometimes it's not. But we're thinking for patellofemoral pain, like you said, front of knee, gradual onset, most often, generally diffuse. If someone's having an acute traumatic mechanism, if they're having pinpoint symptoms, if they're having more mechanical or reactive knee symptoms, there's less of a likelihood that it's purely patellofemoral pain. And like other things, two things can occur at once. Someone can have patellar tendinopathy and patellofemoral pain, or they can have, IT band syndrome and patellofemoral pain. So it's not that there has to be one specific diagnosis, but at least ruling out the ones that may change management. And to what you said earlier, Marc, in the context of patellofemoral pain, imaging is not recommended or required for this diagnosis, but in the context of wanting to rule out more concerning diagnoses, then imaging may be warranted if someone's concerned about a tibial plateau stress fracture, or there was an acute mechanism and they're trying to rule out ligamentous damage, meniscal damage, whatever that case is. But in most instances, if these things are not high alert, imaging is not necessary for a diagnosis of patellofemoral pain. What are not really considered risk factors for the development of patellofemoral pain, but that are often espoused as these are things that will increase the likelihood of your knee being cranky or having this patellofemoral pain?
You looked into this pretty in depth for the resource guide, so I'll let you answer this question.
Yeah. So there was 2 papers that kind of touched on these things that used to be assumed as higher risk factors for the onset or the development of patellofemoral pain. And now there's just not enough support for them being risk factors. So there's a host of things: age, height, body mass index, Q angle, excessive foot pronation, hip strength, altered foot and ankle biomechanics. All these things have been listed in multiple research papers that they aren't a risk factor. So spending excessive time focusing on someone's foot pronation or their foot biomechanics or ankle biomechanics, on someone's hip strength, those are quote unquote modifiable things that people may be able to change, but it's not necessary. And it's not an indicator that if these things are present, if there's altered foot, quote unquote, altered biomechanics or change in foot position or hip strength, that it's necessarily the cause of patellofemoral pain. Same thing with height or body mass index or age. These aren't strongly associated or risk factors. And then same thing, Q angle, this kind of position of the hip and the knee and the rest of the lower body is not really considered a strong risk factor, and something that clinicians have maybe learned previously in their school or what patients have been told. But those are things that really aren't high up there. There is not a ton of strong research for what are these really strong risk factors, but those are the ones that we know for sure aren't them. What we do know is populations that are commonly affected and who may be at a higher risk. And those, again, maybe aren't necessary risk factors, but they're just people that are more commonly experiencing or diagnosed with patellofemoral pain, and where there's research suggesting this. So military recruits, recreational runners, and adolescents, those are kind of the 3 common populations. And within adolescents and within recreational runners, there tends to be a higher prevalence of females diagnosed with patellofemoral pain than there is males. And from my understanding and listening to other researchers, I don't think there's a great understanding as to why females may be at a higher kind of probability of diagnosis with patellofemoral pain or experiencing it. But they are more commonly affected than males. Anything you want to add to that kind of populations affected or not risk factors for patellofemoral pain, Marc?
Yeah, 2 things I want to touch on there. One being that with the discussion of risk factors, it's really honing in on this idea of causation that I think some clinicians or coaches or trainers use to support their own treatment methodology, right? But I do want to say we can't necessarily say that none of these things they don't ever influence patellofemoral pain, right? Because sometimes maybe these things might, and we can hypothesize how they might, especially with the person in front of us, but we're just not saying these things are the cause of your pain or these things are the cause of patellofemoral pain, at the population level. And once again, maybe we'll touch on theoretical possibilities for some of these things. And then in terms of actual risk factors, Chris did include a systematic review and meta-analysis by Bradley Neal et al. And we've had Brad on twice to discuss patellofemoral pain. And in that systematic review, right, they list 2 things as risk factors. One is quadriceps weakness in military recruits, and then higher hip strength in adolescents. And I just wanted to touch on that because you might see that. You might look at the systematic review and say, wait, higher hip strength is a risk factor for patellofemoral pain. And the reason that it might be this quote unquote risk factor is that this population is just more active, right? So that higher hip strength might be a proxy for their activity levels, and that higher activity level might be a contribution to their patellofemoral pain. Not necessarily that being stronger means you're more likely to have pain.
And then for the first one, the decreased quadriceps strength or quadriceps weakness, what would you explain as to maybe why that finding is present?
I don't know if this hasn't been borne out in a lot of research, because obviously this is, the one systematic review that demonstrated that. But, there are findings of, hey, there are individuals with patellofemoral pain with atrophy in their quads, and, maybe they do have quadriceps weakness. So, potentially there is some component, and one of our recommendations is going to be, knee extensor strengthening. So maybe there is a component there with strength, load tolerance, capacity, whatever words we want to use. I'm not sure if there is another, the same kind of proxy that I just described for the adolescents. But I'm not going to hang my hat on anything confidently, because I don't think even, Dr. Neal or others would do the same.
Yeah. And I don't know if that is also the quadriceps weakness shows up because when they test them, they have patellofemoral pain. And if they're trying to do force testing of the knee extensor mechanism and it hurts, it may show up as knee extensor weakness or quadriceps weakness. But is that the cause of their patellofemoral pain, or is it a byproduct of the knee hurts and we're going to modify or minimize the amount we're going to push in for testing?
Well, these were prospective studies that they looked at, I believe, but either way.
Yeah, true. This is a small point, but people that experience patellofemoral pain, they may hear joint noise while going through squatting or going up and down stairs and think that they are at, continued worsening of their joint as a whole, or their knee symptoms are going to worsen because they have what's called crepitus, but essentially these noises within the joint as you go through certain ranges of motion. Marc, what is your understanding of the joint noise or this crepitus? Is this something that individuals should be concerned of or worried about when experiencing patellofemoral pain?
Yeah, I think a lot of patients believe that to mean that there's bone on bone, there's wear and tear, there's long-term joint damage. And there's actually a nice qualitative study by Claire Robertson and colleagues in 2017. And she goes by Claire Patella, I think, because she does so much work on the knee and patellofemoral pain. But the title of this qualitative study is People's Beliefs About the Meaning of Crepitus and Patellofemoral Pain and the Impact of These Beliefs on Their Behavior, a qualitative study. So typically with qualitative studies, they'll separate these different discussions and beliefs into different themes. And I'll touch on a few quotes from the participants in this study, and then we can discuss what that might mean for their actual treatment and management. So an example, the theme of belief about the noise, one person said, "It makes me very emotionally uncomfortable and worried about why and what is happening and whether I made something worse, very much the unknown." Somebody else, in terms of their beliefs, said, "It is the fear that comes with the noise and the fear that it is causing long-term damage. The crunchiness disturbs me. It makes my skin crawl because it does not sound healthy." And then there's emotional responses, there's influence of others. So when I used to do yoga, everybody in the place could hear them. I really did feel embarrassed. I couldn't stand it, so I stopped. I am more conscious of it if I'm around people. I do not like it, so I attempt to sit stiller. If I was with my mom, every time, it's mom, I think this was, maybe in England, but if I was with my mom, every time it makes the noise, she sort of winces. If my daughter and husband both hear the grinding noise, they both go, shh, at the same time, and my husband goes, ah, stop it. Here's one more. My mother will say, your knees are not so good, telling me not to kneel down, or if I'm doing jobs with her, like gardening or whatever, she'll be like, get out of the way. I'll kneel down. But she is in her 60s. So it's obvious that their beliefs might influence their decisions on what they decide to do, with their activity, but not just their beliefs. It's their interactions with others, right? Like that social response of, well, my own family is making me feel maybe guilty or shameful for something that I can't control. So that's influencing things. And then I will say, and this is what we'll talk about, there's two other quotes. Having spoken with my physiotherapist, I know it is not actually an effect of what I am doing. You know that it is a common thing. So I decided to kind of get on with it. And another one, the explanation was helpful. Even though I don't like the noise, I now do not stop doing things because of this, right? So as physical therapists, as clinicians, we can appreciate that patellofemoral joint noise, crepitus, is problematic. It's problematic based on the beliefs that patients have. It can be problematic based on their interactions with others. But we as physical therapists can reassure them that noise isn't causing damage. It's not a response to their joint being bone on bone. It's not wear and tear. And there is a paper by De Oliveira Silva et al. In 2018 that investigated the relationship between crepitus and function, physical activity level, and pain in women with and without patellofemoral pain. And so the participants with patellofemoral pain were more likely to present with crepitus. But the authors also concluded that the knee crepitus has no negative impact on function, physical activity level, and pain of women, because there's women in the study with patellofemoral pain. And then this crepitus was also present in 33% of the asymptomatic group. So if you take 100 people with patellofemoral pain and 100 people without patellofemoral pain, the people with patellofemoral pain are more likely to experience crepitus. But that crepitus doesn't necessarily have to impact their activity choices, their lifestyle choices. So it's important to reassure patients that crepitus shouldn't necessarily exclude them from certain activities or exercises, simply because of a noisy knee.
Do you have any ideas as to why it would be more prevalent in individuals with patellofemoral pain? Actually, what is going on in the knee for that joint noise to be occurring?
I'd rather not hypothesize, but
sure,
it's like discussions that we've had with tendinopathy too, where if you are experiencing tendinopathy, you can almost be sure that if you were to do some kind of imaging on your tendon, that there's going to be these, tendinopathic or these, tendinosis type changes. And so, but that alone doesn't necessarily influence what your rehab is going to do. And I think the same thing for patellofemoral pain is that, if you have patellofemoral pain, more likely to hear these noises, but it doesn't necessarily have to influence management.
Going into the prognosis of patellofemoral pain, when a clinician is trying to figure out, okay, this management strategy or process with a clinician or with a patient, or patients trying to figure out and ask, how long will it take till this improves? What do we know around the prognosis and the overall trajectory and recovery of patellofemoral pain?
I'm going to let you take this one as well.
Yeah, sure. Well, I can talk about my own experience. I don't know if all these episodes are just going to be my own ailments, but I've experienced patellofemoral pain for off and on for over 10 years since I was a teenager. But what we now realize is, and what used to be assumed, was that it was a self-limiting condition, meaning that if you weren't to do anything with this diagnosis, it would naturally go away without any specific type of treatment, just time itself. Now, with more and more research coming out, patellofemoral pain is not considered a self-limiting condition, meaning that some level of intervention or management or adjustment to activity or to someone's lifestyle should occur to help manage and improve someone's overall symptoms. But there's been multiple studies that have tracked individuals with patellofemoral pain over multiple years. And over time, 2 years, 5 years, 8+ years, there's still individuals experiencing symptoms to some extent. Lankhorst 2016 and Ratliff 2016, there were 2 papers that kind of just touched on saying that this isn't a self-limiting condition, but in their groups, they said there is a poor prognosis with over 50% of individuals reporting persistent pain for more than 5 years after initial diagnosis, even with treatment. So even if people are receiving the best quality care and managing things in their life, they still may experience some level of symptoms despite the management strategies in place. But we do know that this is not a quick resolution of symptoms in most instances, and people can experience symptoms for multiple months or multiple years. And this can be also thought of as the tendinopathy conversations we've had in the past, where it may go on for quite a long period of time. But despite that, people can still live active, healthy, normal lives with these fluctuating symptoms that can be chronic in nature. And looking at patellofemoral pain as more of a long-term diagnosis to manage and to work around or work through, as opposed to curing and solving within a short period of time. Anything you would add to that, Marc?
We discussed this with plantar fasciitis, but with this research and with all the research, I try to tailor my recommendations to the patient in front of me. So if we take that research of 50% of individuals will still report persistent pain at some point, many years out. Well, let's say I take a 30-year-old patient who's never experienced patellofemoral pain. They just started running. They really ramped up their mileage in preparation for whatever race. And now they've been experiencing patellofemoral pain for the past 2 months. I might have a discussion with them and say, because they heard our podcast or they read some information that people will have it for many years, I might say, yeah, there is a likelihood that you could experience this on and off for years, or there are individuals who experience this for years. But given the fact that you have no history of knee pain, there's a very clear mechanism of injury here, at least in the sense of you never ran before, you started running and you ramped up your mileage. You've only been experiencing pain for the past 2 months and you're otherwise healthy and active. I'm anticipating this to likely get better within a few months, but let's try to give it a few months, see how things go, and tailor our management from there. But that's a way that you might tailor that conversation to a person in front of you versus same thing. You come to see me, Chris, and you said, well, I've had, patellofemoral pain on and off for years. And sometimes it limits my activities and sometimes it doesn't. And I can't do this and I can do this. Then that conversation might look a little bit different. And it's not ever to give false hope, right? It's not to say I'm a guru. I know all things patellofemoral pain and I'm going to get you better in 6 weeks with my, special training methods. It's just, once again, taking that research, but also applying it to that person in front of you.
Yeah, the predictor for the persistence of a lot of different conditions like persistent low back pain, but also in the case of persistent patellofemoral pain, an indicator is someone's experience or history with said condition. So like Marc just said, if someone's coming in with 3+ years, a year plus, whatever it is, of already experiencing these symptoms, that's different than that individual you said, that recreational runner who's coming in, has experienced it for 2 months, has never had a previous history and hasn't tried any management approaches. That may be a more, optimistic recovery timeline than an individual who's already had it for multiple years. Let's go into when someone has it, whether it's this acute, or subacute, they've had it for 2 months, or now someone's experiencing it for multiple years. The recommended treatment and management strategies. Let's start with education first. I'll leave it up to you, Marc, if you want to dive into it first, or if you want me to. But what are the big things we should discuss with individuals, or the common recommended education points to hit on with patients experiencing patellofemoral pain?
I think there's two ways to think about this. The education can come from what we think is important and perhaps what research tells us is important. But the other side of that coin is educating patients on what they think is important. Same thing, that person in front of us. And so there might be one person who's really worried about this crepitus, or they've been given this diagnosis of chondromalacia patelli, and they think that every time that they exercise, they're grinding down this already soft cartilage on the back of the knee. Then that's going to be a component of your education. So for me, that's a big thing, is understanding what's important to the person and not just assuming what is going to be important to them. So all of the things that we talked about, hey, you've been given a diagnosis of chondromalacia patelli after you got this imaging. What does that mean to you? And if that person tells you what I just said, that is an opportunity for education. Hey, you told me that your joint noise, that grinding, that cracking, that popping is very worrisome. It's very bothersome. It stopped you from walking. It stopped you from running. Rather than me now educating them about what that means, it's taking it one step further and saying, well, what does that mean to you? Why did you stop doing those activities because of that noise? And then you might hear a lot of those things that I read out from that study from Claire Robertson. So to me, that's important. If there are other components of this, common narratives of tight IT bands, weak VMO, patellar maltracking, once again, I'm not going to start with these things voluntarily on my own. But if that comes up in the conversation with the patient, those are things that we're going to discuss. And it's not going to be in a confrontational manner. It's not going to be I'm in a position of power and this is exactly, why it's wrong or what you need to do. It's a conversation to see if I can better understand their perspective and help them to understand, where I'm coming from as their healthcare provider. And then, beyond that, thinking about patellofemoral pain as a diagnosis, what we talked about is that in general, it's non-traumatic in nature, right? It's this insidious onset and generally related to some form of physical activity. If we're thinking about adolescents, that's going to be kids who are participating in sports. And if we're thinking about, more of the general population, as we talked about, that could be military recruits. That could be runners. That could be people who took up cycling on their new Peloton as a hobby. And we get, other things too, the prognosis, whatever else. But then just trying to help them understand, okay, let's talk through this history. You weren't experiencing knee pain. You picked up running or you picked up cycling. You increased your mileage over the past 3 months. You can ask them again, do you think that influenced the development or persistence of your symptoms? And that person might recognize, oh yeah, you know what? My knee was feeling pretty good until I did this, this, and this. And then your education might really just come down to kind of load management, activity modifications, and eventually this gradual reintroduction of whatever activity it is that they want to do. So that's in general how I would frame it. Obviously, we can be much more specific with specific interventions, in specific case studies. But what are your thoughts?
Yeah, I think this can go for pretty much any diagnosis or presentation someone's coming in with. The shift in I am the clinician talking at you of these are the 5 points that I want to hit on, or what was used to be really popular, the pain neuroscience education. I'm going to explain your pain to you, and that very kind of top-down approach. And to what you're saying, Marc, it's hearing what individuals have been told what they're concerned about, what specific questions they have, what they're reducing or taking away from their life. And then with all of that information, navigating that and building upon it with communication, with specific kind of follow-up questions, and then hearing from the individual, what do they want to know about this condition, as opposed to, these are the things that I think you have to know. And maybe some of them are important to touch on, even if someone doesn't specifically ask, but tailoring it to the individual. And this can go into kind of our conversation around exercise, but we know that reassurance, communication, discussion on the topic of what it is and what it isn't is extremely helpful, but we have a lot of flexibility of how we go about those discussions and what we do tell an individual, tailored to what their experiences are, what specifically they're concerned about, and what questions they have. So let's go into the exercise component of management of patellofemoral pain, which, if anyone's listened to previous conversations with Dr. Brad Neal or any other patellofemoral pain researchers, exercise is a large component of the management and progression of rehab. Marc, can you touch on, from an exercise standpoint, where do we typically start, or what are some things we should consider with introducing or modifying exercise?
Yeah, and I think this goes back to the education about what patellofemoral pain means, or what we think it means, right? And telling someone, hey, it's not your ACL, it's not your meniscus, it's not arthritis, it's not your MCL, it's not all of these things. It's this thing. And yeah, it's a fancy way of saying your knee hurts, which you've already told me. But really what it means is that joint, right, where the patella meets the femur, it's irritated. And our best interpretation, our best understanding is that it's irritated based on the amount of load that it experienced in, a given moment or repeated moments, right? We think of it as kind of like this overload of the patellofemoral joint, and the patellofemoral joint does have to undergo a lot of load. The patella is a way to increase leverage of the quads, right? So it's an important joint. And so with that being said, trying to understand exercise selection is kind of based on that understanding of, okay, maybe we overloaded this joint. And if someone there's, once again, different ways to look at this. Back in the day, it was, let's do all glute exercises or all hip exercises. And that might work for a certain amount of time because you're offloading something that is irritated. That makes sense. Like if you have patellofemoral pain and you lie in bed all day, like you've resolved your patellofemoral pain. You're not going to experience patellofemoral pain from lying in bed. And so the same thing, if the approach is only going to strengthen the hips, sure, that might work, but you have to reintroduce the, that exposure to knee loading. So I think it depends on the person that we're seeing. And, I know the research would suggest that a knee focused, program is more important than a knee and hip focused. And I think if we apply that, let's use a runner as an example and just try to be consistent with that. So let's say we have a runner who did increase their mileage and they're experiencing patellofemoral pain. If we're going to introduce exercise, we can't introduce exercise of, more knee loading on top of already their high mileage that is contributing to their symptoms. So as part of some kind of exercise prescription, there has to be a reduction in that load in some other way. And that other way would be, hey, let's cut down your running speed, your running mileage, your running frequency. And in the meantime, let's try to load your knee extensor mechanism, your quads, to better tolerate those loads that you're experiencing with running. So that would be kind of my general framework for exercise selection. And if we're approaching it from the perspective of do as, much as necessary, but as little as possible, that might just be one squat or, seated leg extension exercise 3 times per week, or that could be a full, comprehensive lower body program that includes knee extensor strengthening, hip strengthening, calf strengthening, all kinds of things, depending on the person's goals and time availability and whatnot. I think people liked some of the previous case studies, and hopefully I'm not recalling this incorrectly, but I'll give the case study of my wife, Nicole Surdyka, who has been on the podcast. And from what I remember, when we first met 10 years ago, she had pretty irritable patellofemoral pain. And for those of you who don't know, she did have an ORIF 10 years prior to that. And so, that's probably contributed to this history of patellofemoral pain. But so for, 10 years ago when we met, she would have a very difficult time doing leg extensions, like any amount of load, any range of motion, very painful. And I would try to convince her, hey, why don't you try to load this a little bit? And it'd be one of those things that, maybe it goes well for a while. There's a flare up, you back off, you can't find the good range of motion, the load hurts. And all that to say is over the past, 10 years, she's found, okay, isometrics are comfortable for me. Low load is comfortable for me. Now the shortened range of motion is comfortable for me. And just like 2 weeks ago, she told me that she hit, an all-time personal record on a single leg seated leg extension. And she also can't recall the last time that she's had knee pain, right? So that was an example of targeted exercise selection for her. And it took, many years. And I'm not saying that that's like the, the sole reason for her knee getting better or whatever, but that's an example of, targeted knee exercise that, needed to be tailored to her specific needs.
Yeah, I think what can also be helpful for patients coming in, if they're really fearful about loading their knee because they've offloaded or avoided going into deeper knee flexion angles, or doing something like a seated leg extension, building trust and rapport and buy-in through hip and other lower body related exercises that really aren't putting the knee joint in that much of a stressed position or loading the quadriceps, because it's likely not going to be that symptomatic, and at least gets them to start moving, and then slowly dosing in some level of quadriceps and knee focused loading, whether it's through a wall sit variation or turning an RDL or hinge into more of like a squatty deadlift, or ways to kind of step into more progressive or more concentrated loading of the anterior knee in a manner that the person feels comfortable with, that they trust you already, as opposed to, well, we know loading the quadriceps and the front of the knee is strongly recommended. Let's do this day one. You light them up. One, maybe because you just did too much too soon and they've been avoiding those things for quite a long period of time. And then two, you lose that initial trust and rapport that you're trying to build with patients. So the end goal is for someone to expand their overall tolerance and capacity for loading the knee joint in a variety of different positions, velocities, loads, frequencies, etc. But you don't have to start aggressive day one, and you can slowly ease into it through training the hip musculature, training the calves, training the trunk, and then dosing it in appropriately over time as someone is ready. I think that's a more realistic and a more sensible approach than forcing too much too soon. And this can occur or relate to most rehabs in general.
Yeah, loading an already overloaded system is not the answer, at least initially. Like, it's okay to back off. And another thing is that we often associate isometrics of the knee extensors or other muscle groups with tendinopathies, but isometrics can be beneficial here as well. We had a previous discussion, a myth busting discussion about leg extensions and what it means to quote unquote stress the knee, because people say, well, this exercise is too stressful, without understanding what stress means. And a quick recap of that discussion was that stress is force over area. And as it relates to the knee, the force is influenced by the knee flexion range of motion and the amount, like how hard the quadriceps are contracting. And then that area is just the amount of, patellofemoral contact. And that changes through different ranges of motion. And so if somebody is worried about, let's say, leg extensions, because with a really high load and a very straight knee, technically, that's a higher stress on the patellofemoral joint. But you could try to change that by doing an isometric at 60, 70 degrees of knee flexion, where that knee is, the patellofemoral joint is technically experiencing less stress. So there are ways to try to modify things. And I think the other thing that's helpful to understand is that, at least the way I think about it, patellofemoral joint stress is not evenly distributed throughout the range of motion, right? Like the patella contacts the femur differently. And so that force is distributed differently throughout different ranges of motion. So you might find that someone's doing a squat and they have, pain at a specific range of motion, but they don't have it above or below that range of motion. Well, then you can do shortened range of motions or shortened range of motion or isometrics above and below that, and then gradually expose them to that one specific 10-degree angle that's painful. And if you go to the blog on, E3 Rehab, in which I write about leg extensions, you can see an image of, how the patella, contacts the femur differently at different ranges of motion, just to get an idea of kind of what that means.
Something that also may be helpful to discuss with patients or to view as well as a clinician, and I feel like this wouldn't be a true patellofemoral pain episode if we didn't talk about Scott Dye, but this surgeon back in the mid-90s talked a lot about this kind of theory or this way to think about patellofemoral pain or knee pain in general called the envelope of function. And he's got kind of an iconic paper from, I think, 96 talking about the envelope of function. But there's a graph that he puts in there looking at as load increases, these are examples of what an activity may look like. Jumping from a 2-meter height, and as frequency increases, something like walking 10 kilometers, these are the things that you can do along this graph that is tolerable for your system, and tailoring this to each person, saying like, your knee joint is able to tolerate, the good news is your knee joint is able to tolerate XYZ thing. Our goal is to expand this kind of graph of options for you over time, whether that's doing more of something over a long time, the increase in your duration, or increasing the intensity or the load of something. And some clinicians or some patients might find that helpful to have kind of a realistic and also optimistic approach of, these are all the things that fall within your tolerance at this point in time. These are the things that you're saying you're limited by or that you want to get back to. Looking at kind of this graph, this is where we need to go. And that may not be helpful for everyone, but for some people kind of getting a visual, I'd recommend reading that paper, and we can link it below, and it will be in the practical guide as well. But not viewing, kind of like Marc said, not viewing stress or load to the patellofemoral joint as good or bad, but as this is currently what you can tolerate. These are the forces of the activities you're doing. We're agnostic about these activities, but if you want to get back to them, we know this is what you have to build back up to.
Another good paper there is Tissue Adaptation to Physical Stress, a proposed physical stress theory to guide physical therapist practice, education, and research, by Michael Mueller and Katrina Malouf. And like Chris said, the idea is that stress isn't good or bad. You want to improve your heart health, your bone density, your muscle mass. You have to apply a certain level of quote unquote stress. And if you completely remove that stress, your heart health, your bone density, your muscle mass will get worse, right? And if you do too much, maybe you get a bone stress injury. So there's, you might get rhabdo. So there's that balance of stress isn't good or bad. It's just the right dosage at the right time with the right recovery, et cetera.
So outside of the exercise piece, modifying the more aggravating activities, building their system up over time as a whole through isolated quadriceps loading, through combined hip and knee, through just general resistance training and graded exposure to the more provocative activities. Another big recommendation, and we discussed this with Brad Neal when he was on, is the utilization of foot orthoses, as this has quite a bit of research suggesting that it can be helpful for individuals experiencing patellofemoral pain. Marc, do you want to touch on these recommendations, or would you like me to?
Yeah, it's a pretty simple recommendation, right? The foot orthoses or orthotics or inserts or however you want to call them, you can just get them off the shelf. You can order them on Amazon, and as long as they're comfortable, it's pretty much a no risk intervention other than, you know, the money that gets pulled out of your wallet. But it's something that you could try and go, hey, you know what? This patellofemoral pain has been pretty persistent. I'm not able to exercise at the level that I want to. Let me try these things for however long and see how they feel. And if they seem to improve my symptoms, great. If they seem to make no difference, well, you know, I'm out $30, but at least I gave it a try. So it's a pretty, like, yeah, you know, I won't say no risk, a pretty low risk thing to try.
Yeah, I was re-listening back to the conversation with Brad, and I had asked him, is there much of a difference between these prefabricated orthoses, essentially ones you can buy at the store, order on Amazon, versus these self-made custom orthoses that you can get from a podiatrist or another healthcare provider? And his answer was, long story short, not really, but similar to the exercise component, you can experiment with different orthoses, and they don't have to be these custom orthoses that you pay significantly more for, but you can experiment with the cheaper alternatives of ones with a little bit more heel support or arch support or specific cutouts or whatever it is. That the end goal is finding one that's the most comfortable. And this can go into like shoe-based conversations as well, as there's not one better or worse footwear option, and there's likely not one better or worse orthoses, especially in the context of patellofemoral pain, but maybe exploring a few options and seeing which one may improve or dampen down the intensity of your symptoms throughout the day. And there isn't, to my awareness at this point in time, any long-term studies tracking how long someone has to have it on for. I think what Brad had said in our conversation was they go up to 12 weeks or less, these studies looking at foot orthoses. So we can't say that, and we shouldn't say that someone for the rest of their life has to utilize these orthoses. And if you don't wear them, your symptoms are going to worsen, but it is a low cost option. It's something that if people experience relief, they can utilize it. And over time, if someone wants to remove them, there can also be that kind of graded removal of the foot orthoses back into their, you know, their normal shoe wear without it, or footwear. And I think Brad made a good point of, and I had thought about this for a while, that foot orthoses are inherently bad to provide to people because it's a quote unquote passive treatment option and we need to provide active care. But his narrative, and I agree with this, is that they are hopefully helping someone be able to tolerate activities and do more of the things that they want to do or need to do. And that it's just an option to provide those opportunities for more activity or to tolerate a set level of activity. And that the narrative that the provider is giving is the biggest thing, that you're not telling them that these orthoses are changing the position of their foot, or that they are fixing the posture, the biomechanics of their foot and ankle, and that's why it's alleviating or improving their patellofemoral pain symptoms. You can kind of be honest, we don't have a great answer as to why it helps individuals, but we know that there is significant research to suggest that it can be helpful. Let's give it a shot, as opposed to these really black and white answers or incorrect assumptions or explanations as to what it's fixing with someone, where we just don't have that support in the research.
Yeah, there's no prerequisite foot shape, arch height, etc. for trialing this. And I will say, to something that you said to some extent is that don't, even though it's not necessarily this just passive intervention, don't use it as a replacement for intelligent decision making. Meaning that if your symptoms started after you ramped up your running mileage for a marathon, and with each consistent increase in mileage, your knee pain is getting worse, don't then say, well, I'm going to continue with this running plan and just throw foot orthoses into my shoes and call it a day. Like, you still need to manage your running mileage and your overall load. And then you can also consider the foot orthoses. Now, if your marathon is tomorrow, or actually, I wouldn't even recommend that because you don't know how you're going to respond to that. So never mind. I guess maybe with like tape is different, but I probably wouldn't do that with new pair of shoes or new foot orthoses the day before a marathon.
Yeah, what we had discussed earlier, these common populations that are affected are individuals that appear to be doing more than they are prepared for or that they can tolerate, and they don't have maybe a ton of background in those set activities. Military recruits asked to spend a lot of time on their feet, rucking, running, these other physical demands that they may have introduced in a large bolus than what they can handle. Recreational runners going from maybe no running at all or minimal running to spiking the frequency, volume, intensity. And then adolescents, maybe similar, of doing just a lot of their sport or just being physically active. And to Marc's point, the low-hanging fruit, or maybe the big rocks, are we need to talk about the overarching, this is what you're currently doing in the course of a day or a week or a month, and this is the amount of activity that you're doing. Just throwing on a pair of foot orthoses likely will not be the only thing that needs to occur if someone's just general activity levels or loading of the patellofemoral joint is too high for what they can tolerate, and or it's not supplemented with more directed lower extremity loading or knee extensor loading. And it shouldn't be in isolation the only management strategy for an individual experiencing patellofemoral pain.
And I would say for adolescents, never make an assumption of their activity level based on your own experience, based on friends and family. Ask. Like I said, I lived in LA for a long time. I worked with, kids of LA parents, and I'd hear them doing 8 hours of tennis every single day, and my mind couldn't even comprehend it. Like, what are you doing for that length of time? Why are you doing it? So maybe that just shows how unathletic and, low aspirations, I was as a child. But to understand their activity level, it blew my mind. So when they said, oh, I have elbow pain, to me, that made complete sense. And so, two things there is, one, trying to throw exercises at them. It's not helpful. It's not going to do anything. You got to cut back. But then you also have to realize that these kids or families might not cut back. So just don't make assumptions about someone's activity levels. You got to ask.
There's a variety of other treatments that clinicians will commonly do or that are discussed in the literature that may be worth briefly touching on. To your previous examples or the repetitive example of the runner, something like gait retraining or changing someone's cadence is commonly talked about or sometimes utilized. Do you want to touch on maybe the usefulness of gait retraining in certain contexts, or what your take is on that management option?
Yeah, and I'll say that my bias is self-management, right? Like that's kind of a lot of what we do here at E3 Rehab, is trying to promote self-management. And I see a lot of these things as self-management, and I see them as kind of a form of load management in a way, like if someone's running and you reduce their amount of mileage, that's load management. You could maybe even consider foot orthoses as a potential form of load management if potentially those foot orthoses are, distributing the forces differently at the knee, maybe. And you can view running retraining as, potentially load management. If someone's running a certain way that creates more load at the knee, that running retraining is a method for trying to reduce the load at the knee. We could talk about this briefly. We have a great video actually by Jason Torrey on our YouTube channel, who did a full video on like running cadence and its utility, the history of it, the utility of it. But same thing, I don't know if I would say this person isn't doing 180, steps per minute, or this person looks like they're overstriding by half an inch, or, we could try to make some observational analyses or assumptions. You could also just say, hey, let's try to, increase the cadence by however much and see if that changes symptoms. And if it doesn't, it doesn't. And I had that experience in the clinic before. I was lucky that one of my clinic directors was a former Division I track athlete at USC. And so he would help me with my, running analysis and making recommendations. And I remember seeing somebody with patellofemoral pain, and, we had them, and the person had it for a while, got them on the treadmill, analyzed it, and it did look like, hey, you probably would benefit from increasing your cadence. Increase your cadence. Person said their pain went away. Recommended what they could do for gait retraining. I never saw that person again. And, then they emailed me and said, hey, things were fine. That's all I needed. Not to say that that's going to be the case for most people, but yeah, it's an option for load management.
I think a big takeaway that I've learned from mentors and trusted clinicians is also not just throwing 20 different management options at the individual at the same time. So if you have a runner and you at the same time adjust their cadence, increase their cadence, or have some type of running retraining, you put in forward orthoses, you adjust their volumes and intensities, you add isolated knee extensor loading, maybe you do some manual therapy. Let's say their symptoms are improved over the next few weeks and months of care. How confident are you that it's one of those options? It's probably hard to know which one it was, and it probably is a cluster of things. And then if they do get a spike in symptoms for whatever reason, you also may not be totally aware of, well, what was it? Was it the increased cadence? Was it these new forward orthoses? Was it the isolated knee extensor loading? So I think being minimal to start and adding or adjusting one or two variables, tracking that over multiple days and weeks, and then manipulating from there is probably the best option. And this goes outside of the patellofemoral pain case, but for most rehabs, not trying to overload someone's system with 20 different options just because you're kind of wanting to see what works and assuming that the more the merrier, and the better they're going to get is from doing more or trying more options. And that, I would say, likely is not the case and is not appropriate.
Sometimes that approach breathes life into gimmicky treatments also. So person with patellofemoral pain reduces their running mileage, adjusts their cadence, and also stands on their left leg while pulling on their right earlobe, and their knee gets better. And then they attribute it to the connection between their left big toe and their right earlobe. And, it's a silly example, but there are some silly treatments in rehab in general. And I think, sometimes that's how they're given life.
Yeah. And even if you're sticking with one kind of treatment or management strategy of exercise, and then for your session with them, you give them 3 or 4 or 5 different knee extensor loading activities, a handful of hip related exercises, some calf work. They have 10 or 15 exercises. Again, that just may be too much for their system. Like, give them 1 or 2 quad based options, maybe 1 or 2 hip based options, and stop there. And being more minimalist or simple likely is a more useful starting point. It's less for the individual to have to remember to perform on their own, and it's just more realistic. And then you can always build from there, but it's hard to throw too much in and then try to scale back. It's easier to start simple and layer on over time.
And the last thing I want to touch on with regard to treatment is that I know in this big kind of systematic review from Brad Neal that you included in this resource guide, there are some treatments that are not recommended, or there are some treatments that the author state as inappropriate. And I'm not going to contradict that. What I'll say from my own perspective is usually what I tell people is that if it's low cost, low risk, you want to try something out, you're doing everything else correctly, I don't really care. I'm not going to judge you for whatever you want to do, as long as you understand let's say you're like, hey, can I foam roll? Can I tape? Can I stretch? I don't care. Like, if those things float your boat, you can give them a try, as long as you understand that it doesn't have anything to do with your patellar tracking. Like, hey, a foam rolling your leg feels good, fine, but don't do it to the point that it's excruciatingly painful because you're trying to release your IT band, or you're trying to tape your patella a certain way to make it track a certain way. Like, those things, they don't matter. But if you want to try some of those feel good treatments, that's completely fine. To me, it's once again, low cost, low risk. I don't care. We're giving our big buckets of things that I think you should do. But I'm not going to be up in arms if, like the example I was given before, you want to throw some kinesio tape on your knee the day of a marathon, whatever.
Yeah. I think the common response I have, if people ask me, typically there's like kind of two different types of question. It's they've heard about it and they're curious as to whether it's helpful or that it needs to be done, or someone has experienced or had XYZ treatment previously and they're asking if it can be done by you, the provider, or just in general. And I will typically, for that first one, if someone's asking like, oh, do I also need to, tape my knee? I will say it can be an option for some individuals. It's useful, but if you didn't bring it up to me, I wouldn't have strongly recommended it. And just kind of giving that offloading response of, if you didn't bring this question up, this is not something that would be required or strongly recommended for your treatment. But if you'd like to explore that option on your own, you can. And then the individual who's really strongly had a great experience with massage or manual therapy in the past with patellofemoral pain and said that it was super helpful for them, I'm not going to say that you shouldn't have this received or performed on you. But for our time working together, I think there are bigger priorities. However, if there's other providers or individuals, or you yourself want to massage your knee or want to use options like a foam roller to provide that relief, that's great. But it's also not something you have to do. So yeah, it's not shutting down unless I think it's inherently worsening their symptoms or risky, not shutting down their previous experiences or their questions, but also not giving a lot of extra, time and investment on that treatment with the limited time that most clinicians have working with patients.
Yeah, because whether you put some tape on their knee or they do it themselves, it doesn't make a difference, right? So that's what matters. And the only reason I bring this up is because in YouTube videos and podcast episodes, I get asked, well, what about this, this, and this? And in reality, my thought process is, well, if I didn't include it in the video, I probably don't care about it. It's not a recommendation. So in some videos and some podcast episodes, I'll throw in that quick one line of low cost, low risk, have at it.
Anything else with patellofemoral pain you think we should touch on, Mark, before we call it?
I've been saying femoral. Chris has been saying femoral. I taught anatomy for many, many years. Probably doesn't matter that much. Don't stress about it. Whatever you want to call it.
Yeah, am I wrong?
No, I don't know. I don't know if the
PFP gods have made a decision on whether it's femoral or femoral.
Once again, I just anticipate someone saying, well, how come he's saying it one way, he's saying it one way?
Fair enough.
It doesn't matter.
All right. We'll call it there. Mark, thanks for coming on. And for individuals that want to see this guide and download it, this episode should come out towards the end of September. the guide will come out in the 1st of October. So people can sign up for the newsletter. The newsletter will have the patellofemoral pain guide. If you want access to the previous plantar heel pain, plantar fasciitis, and low back pain, you can either message me on Instagram, or in a few months, we'll likely have some of these guides available on our website on E3. So you can also wait a few months, but we're going to kind of collect these over time and have these discussions every month. So hopefully they're useful for you all listening. Okay, well, Marc, we'll call it there. Thanks again.